My name is Logan, and I'm a medical student here to talk to you about assessing and treating pain in older adults with dementia. Specifically, we'll have the chance to discuss the incidence, features, and pathophysiology of pain in patients with dementia, factors that might lead to the undertreatment of pain in these individuals, methods and tools used to properly assess pain in older adults with dementia, and finally, methods for optimizing pain management in these individuals. Did you know that aging adults have a high prevalence of persistent pain? In fact, it's estimated that about 50% of individuals over 80 in the general population experience frequent pain, and up to 80% of nursing home residents have persistent pain. Pain can originate from chronic illnesses, such as neuropathy, osteoarthritis, or malignancy, as well as more acute illnesses, such as fractures, infection, or pressure ulcers. In older adults, even minor insults, such as constipation or dehydration, can be a source of pain and discomfort. The causes and incidence of pain in individuals with dementia are similar for people with those without dementia. Despite this similar incidence, studies have shown that rates of analgesia administration for individuals with dementia is significantly lower than for those without dementia. This means that pain is frequently undertreated in dementia patients. This inconsistency between rates of persistent pain and rates of pain treatment in individuals with dementia is a result of several factors. Firstly, patients with dementia often experiencing varying degrees of memory impairment, and this difficulty with memory makes reliable reporting of pain patterns challenging. Secondly, difficulties with verbal communication may prevent patients from articulating that they are experiencing pain or from asking for help when pain occurs. Also, many patients with dementia have a decreased emotional expression of pain, so that they appear stoic, even when experiencing severe discomfort. And lastly, many healthcare providers have the false belief that individuals with dementia do not sense pain the way that other patients do. In recent years, a number of studies have been conducted to show that this is not the case. Let's take a moment to talk a bit more about the perception of pain and how it might be altered in patients with dementia. The signaling pathway begins when pain receptors, or nociceptors, are activated by tissue damage. The signal then travels up the peripheral nerve and into the spinal cord, where the ascending tracts relay this information to the thalamus. The thalamus then transmits the signal to the somatosensory cortex, where it is deciphered. The thalamus also relays information to the frontal cortex, which is in charge of conscious thought, and the limbic system, which is in charge of emotional response. We know that brains affected by dementia often undergo atrophy with age, and this atrophy often involves the cortical regions involved in pain perception. Because of this anatomical change, a number of studies have been conducted to investigate whether pain signaling is affected in patients with dementia. Thus far, multiple studies have shown that pain signaling is indeed altered with dementia progression. However, evidence has continuously disproved the myth that patients with dementia do not feel pain. A recent study using fMRI and validated clinical assessments showed that while pain and temperature sensation may be somewhat blunted in cases of behavioral variant frontotemporal dementia, sensation of pain and temperature is actually heightened in semantic dementia and in Alzheimer's disease, which we know is responsible for more than 70% of dementia cases. Allowing pain to remain undertreated can have severe consequences, particularly in older adults with dementia, who are already at risk for complications such as delirium and falls. Poor pain control can interrupt sleep, decrease appetite, cause delirium, decrease functional mobility, which increases weakness and falls, as well as increasing the incidence of depression and decreasing reported quality of life. So how can we accurately assess pain in individuals with dementia in order that we might treat it more effectively? Self-report is the most reliable indicator of pain in the general population, and it is a key indicator, even in patients with dementia. If a patient tells you that they are in pain, they most likely are. However, studies have repeatedly shown that self-report alone is an insufficient tool for evaluating pain in adults with dementia. The American Geriatrics Society Panel on Persistent Pain in Older Persons outlines 6 areas that should be incorporated into behavioral pain assessment charts in order to increase their sensitivity. These areas are as follows: facial expressions, such as grimacing or frowning; vocalizations, such as verbal abuse or expletives; repetitive requests for help, moaning or grunting; body movements, such as rigidity, guarding, or agitation; altered interpersonal interactions, including decreased social interactions, combative or aggressive behaviors, or resisting care; changes in activity patterns, including food refusal, sleep alterations, or a change in routines; or alterations in mental status, such as confusion, crying, tearfulness, irritability, or depression. In order to increase the accuracy of pain assessment in adults with dementia, a number of tools have been developed and validated. There are around 40 such tools, and each of these is primarily based on the pain-related behaviors we just discussed. Detailed information and downloadable versions of each of these tools can be found at the link listed. Here, as an example, is one validated tool, the Abbey Pain Scale, which you can see focuses on our domains of behavioral pain assessment: vocalization, facial expression, body language, behavioral change. It also integrates physiologic changes, such as pulse and blood pressure, and physically visible injuries. Having such a large number of validated tools with similar methods of pain evaluation leaves us with the question: which tool should we use? In 2016, a meta-analysis pooled data from 8 systematic reviews and compared 28 of the existing tools. This analysis concluded that no single observational pain scale was clearly superior to any other when evaluating pain in adults with dementia. This review put forth the recommendation for a new approach called PADS, Pain and Dementia Decision Support. This approach emphasizes regular assessment of pain, with particular emphasis on the 6 domains of behavioral expression of pain, as well as regular communication between caretakers, patients, and staff, and careful monitoring of responses to medications and interventions. A stepped care approach to the management of pain has been shown to be effective in pain reduction. Initially, pain can often be relieved by addressing routine physical needs, such as thirst, hunger, poor positioning, or the urge to urinate. If pain remains unrelieved after non-pharmacologic interventions have been applied, pharmacologic treatments can be considered. The evidence-based guidelines from the American Geriatrics Society recommend acetaminophen as the first-line pharmacologic treatment for patients with dementia. Addition of other pharmacologic agents should be carried out with care and awareness of potential risks and side effects. Other agents that may be considered later in the course of stepwise therapy include NSAIDs, opioids, gabapentin, tricyclic antidepressants, and corticosteroids. So in summary, remember that pain is often undertreated in patients with dementia. A thorough and sensitive evaluation of pain in a patient with dementia includes not only the patient's report, but also behavioral indicators, such as facial expressions, vocalizations, body movements, changes in interpersonal interactions, activity patterns, or mental status. There are a number of validated tools for this assessment, all of which rely upon similar metrics and have an approximately equivalent ability to detect pain in adults with dementia. And lastly, once detected, pain should be treated in older adults in a stepwise manner, beginning with non-pharmacologic measures, then with acetaminophen and other pain-relieving medications. Thanks for listening, and best of luck with your future evaluations.